You can see the lymph nodes very easily. And these pictures really can't be beat in terms of looking at this disease process with the multiplanar, multi-dimensional views. So let's see, next slide. So this right here, this is an MRI of a patient that I recently saw. So this is a patient that underwent first colonoscopy and was found to have a malignant polyp. Multiple clips were placed. And basically all they could tell me on the MRI was the distance of where the clips were, because the clips performed all this artifact. So this is a patient that MRI staging wasn't applicable to. I suppose we could have waited longer for the clips to come off, but the clips can last for quite a long time. So when is endorectal ultrasound good for rectal cancer staging? It's most useful for very early stage disease, delineating between the difference between T0, T1, T2. If there are metallic implants and clips, you can still get adequate staging. The ultrasound isn't affected by that. If the patient has an MRI incompatible device, those are patients that need to be staged by endorectal ultrasound. And then the sensitivity and specificity in lymph node staging is actually fairly similar to MRI. The disadvantages are it's really dependent on the operator and the person performing the examination. There's questions about whether you can see the circumferential resection margin on ultrasound, although some experienced ultrasonographers can see it. There's a lot of patient discomfort. Most of these tests are staged without sedation. And then obviously if you have a stenotic lesion, it's very, very difficult to get the probes by those areas and to get a good staging. So I wanted to show you guys what the probe looks like. So this is the probe that we use. This is a 3D ultrasound probe. This piece right here is a cap that you can attach the condom and instill water in it. Because what you need to do is you need to have a balloon interface with the rectum. You don't want air, because the air interferes with transmitting the ultrasound waves. We use a special proctoscope that we do the proctoscopy through, and then the probe goes through that. And the proctoscope creates like a cuff. So then when you inflate the balloon, only the last 6 centimeters here will insufflate in the patient. And the present probe has, what it does is the probe will travel from the end to the to 6 centimeters distal to the tip. And that creates these 6 centimeter boxes of data that we can get in terms of staging. So typically patients are prepped with 2 fleet enemas. You suction out any residue because that's going to interfere with your images. You use the large bore proctoscope first. In the very distant past, there were radiologists doing this without taking a look, and you really can't get good images if you don't look at what you're trying to image. So when you do the proctoscopy, you're looking at where the lesion is. You want to assess and measure where it is and sort of note the morphology of the lesion. It's really important that you have to get above the lesion to adequately stage it. And typically we just try to get as high as we can. And we want to get into above the extraperitoneal rectum. You suction out any debris, and then it's really important to sort of correlate what you're seeing on proctoscopy with what you will see when you get your ultrasound images. So in terms of reading ultrasounds, the main principles are that tissues that are hyperechoic are tissues that have a lot of collagen, like the submucosa or the fat, and these will appear white on ultrasound. Tissues that have a high level of water will appear hypoechoic, so that's muscle, and those will appear black. So basically you're looking at shades of black and white on the ultrasound. So this is our model where the water in the balloon that you insufflate will be black. The first white inner line is the interface between the balloon and the rectal wall. The second line, which is the first black inner line, that's the muscularis mucosa. So that's where the lesions will originate. The most important line to remember is the middle white line. That's the submucosa. That's what's going to differentiate between an invasive lesion and a non-invasive lesion. This black outer line, that is the muscularis propria. And then the outer white line is the interface between the muscularis propria and the fat. It's really the line of the perirectal fat. So one easy way to remember this is what Doug Wong used to teach us. This is the Big Mac model. So this middle white bread, that's the submucosa. And then you got your muscularis mucosa here, you got your muscularis propria here, you have your interface of the balloon here, you have your perirectal fat here. And then that's what you see, these alternating 5 layers in the rectal wall. So again, you want to make sure the patient's prepped. You want to insert the proctoscope, see a lesion. And then when you're getting your images, you might need to vary the balloon volume because you need to have that apposition and you don't want air between your balloon and your rectal wall. You want to make sure your transducer is centered in the rectum, and then you're going to optimize your gray contrast. It's important that you're above the tumor when you're imaging, so you want to get the whole lesion. You want to pick up the corners of the lesion, and you'll see what I'm talking about with that. And then you want to make sure you look for lymph nodes and you image the entire tumor. So when you inflate that balloon, it's typically going to be somewhere between 90 to 150 cc's of water. It really depends on the size of the patient, the size of the rectum that you're imaging, and even the size of the lesion. And then when you hit the button that's looking at creating it, you're actually going to just leave your ultrasound probe stable, and pushing a button to scan the rectum is going to give you a 6 centimeter box of data. And then if you need to look at more, which most of us would have to, you then move and you get another 6 centimeters of data. So this is an image of where you would have to put more water in the balloon because there's a lack of apposition here. This is not a lesion. This is just a lack of contact between the 2 images. You can tell that the images are much clearer when the probe is centered versus the lack of clarity with a non-centered probe. And then obviously you can get more definition if you're using all your shades of gray as opposed to lacking the contrast. And this is just one of the fine two nodules you can use on the machine. And then really what you're looking for are these nice, clear 5 layers of alternating white and black. And then you can actually see that on this 3-dimensional cut view as well. So looking at some normal anatomy, if you were sitting in the rectum looking forward in a male patient, you can see the bladder, the seminal vesicles, and the prostate. And here what you see is this is what the bladder looks like anterior to the rectum. This is what the seminal vesicles. When you start moving and looking at things, you can start getting cuts of the seminal vesicles that'll actually look like lymph nodes, but it's really important to realize that you're just seeing a part of the seminal vesicle before you get the whole view of it. And then down here, you see the level of the prostate. And sometimes the rectum can actually look a little bit triangular right behind the prostate because it's flattened out in the anterior portion. On a female view, if you're looking at this level right here, rectum, vagina, bladder, you can see rectum here, vagina, you can see the white of the air in the vaginal lumen, and then you can see the hypoechoic fluid of the bladder right there. What you can look for is branching of vessels. This looks different than a lymph node because it's the very same echogenicity compared to the water in the balloon. These are loops of valves, so you can see in the intraperitoneal rectum, you can really tell whether your lesion is intraperitoneal or extraperitoneal, if that makes a difference for you when you do your TEM or TAMIS. So it's important to look at all levels of the tumor. So this tumor right here looks like it's a T1 lesion. You see this nice intact muscularis propria here. But then if you go down a little bit inferior, you see this change where there's expansion of that muscularis propria indicating a T2 lesion. And then you really want to look for lymph nodes. They typically have the same echogenicity as the tumor. So here's tumor right here, lymph node here, lymph node here. So just to remind you about rectal cancer staging, T0 is non-invasive, combined to the mucosa. T1 is where the tumor will extend into the submucosa. So you're going to see a break of some sort in that white line. The T2 usually looks where it goes into the muscularis propria. So what that looks like is an expansion of that layer. T3 is when it extends into the perirectal fat. T4 is invading another adjacent organ. And then we really just look for node positive disease as opposed to looking, and what we can't see obviously are those lateral lymph nodes. So here's an example of a T0. You're going to see that intact white line all the way around, intact white line right here that you can see. T1, you're going to lose that white. And often what you'll see is almost like a dotted line that looks like stippled. Here you can see coming in from the corners, loss of the white line, loss of the white line, but you can still see a very nice intact black line of the muscularis propria there. These are other examples of T1. You see some stippling and loss of that white line right here. This is a lateral view or sagittal view where you're looking and seeing little losses of that white line, but nice intact muscularis propria above it. T2 lesion, really, I think of it as an expansion of the muscularis propria. It tends to look pretty smooth right here. Here's expansion here. More examples of T2, nice and smooth. You can see no stippling here. Here you see a very clear break in that submucosa and expansion of that muscularis propria. T3, usually you see the scalloping of the perirectal fat, and then so it's not an easy smooth border that you'll see. Here are more examples. T3 scalloping right here, lateral view of scalloping of the lesion, very irregular. And then a T4 is obviously invasion of another organ. This one might be a little bit difficult to see, but right here, the vagina is anteriorly. You can see that there's some invasion of the vaginal wall. This one's a bit easier to see. This is a prostate invasion. This is the prostate right here. There's no line right here between the tumor and the prostate. Here's the same patient with a sagittal view, and here's prostate right here. You can't see that clear border right there. And then here are some more examples of lymph node disease. Again, the lymph nodes have similar echogenicity as the tumor. So the 3D does give us some benefit where you can come in on the side and make sure that this is not a branching vessel, as you can see on this image over here. So it does make our lymph node staging a bit more accurate. So accuracy, as we said before, is somewhere between 74 to 90%. Typically, if anything, we overstage compared to understage. Lymph node metastasis staging is fairly similar to MRI, except for those lateral lymph nodes, which are becoming more important. And the distance to the mesorectal fascia can be difficult to see. So this is Julio Santoro's data of using 3D ultrasound, which is what most of us who still do this are using right now. It does help both of our RT staging, and most of the failures of staging is overstaging T2 disease. So again, the limitations. The biggest thing nowadays is that it's hard to teach people how to do this because it's a steep learning curve. It's over 40 patients, and we aren't really staging as many people by ultrasound anymore. And then, people can look at the same ultrasound, and there can be different levels and differences in interpretation. So observer differences. And usually the person who does the exam actually has the highest accuracy. The ultrasound equipment is really, it's limited based on its transducer focal length, so you can't see as far away from the probe as well. And again, it's difficult to see the mesorectal fascia being with the distance it can have. And then the things about the disease that is no different than when you stage by MRI is that, neither test is good for microinvasive disease. It's hard, you can overcall things when there's peritumoral inflammation. And then if you have a post-polypectomy inflammation or biopsy artifact, that can affect both kinds of stages. This is a patient of mine who had actually a squamous cell of the anal canal that was involving the upper rectum. You can see part of the puborectalis muscle here. This is the tumor right here. There was a question on the MRI whether it was invading the vagina. This is a sagittal view where you can actually measure how the length is. And then this is the patient. I actually put the probe in the vagina first, and you can actually see a very clear border between the vaginal wall and the tumor in the rectum. So this was a T3 lesion, not invading the vagina. This is a patient who was sent for TEM. It was thought to be an early lesion. You can measure the angle of what your resection will look like. You can see that there's that break of the submucosa indicating a T1 lesion, but in an intact muscularis propria. You can see nice intact muscularis propria on this sagittal view, but this patient had a few lymph nodes. So this was actually T1N1 disease. So this is just what you would get if you're interested in staging. This is probably not the best reimbursement because these rectal cancers do take some time. So you really just want to be able to do this for a selected few patients that you're trying to work out for TAMIS or TEM for the most part, and for those rare patients that have clips or can't get MRIs. But these are the same billing codes that are used for anal imaging as well, and there may be a better yield in terms of someone who's in private practice and trying to get up their billing and RVUs based on that. It's important to know that you can do these 3D rendering, and you can bill a little bit more by using those codes. So going on to endoanal ultrasound, we can use ultrasound to look at the anal canal in terms of assessing our patients with fecal incontinence, in terms of imaging patients that have an abscess or fistula, and then occasionally you can do it for patients with anal pain. It's the same probe, but you don't use that balloon. You just put the condom over it because the anus obviously closes around that probe, and so you get the contact without a lot of air. Typically, I teach people how to read ultrasound, again, looking at the proximal, mid, and distal anal canal, and I'll show you some representations of what that looks like. And the puborectalis looks like a U-shaped structure. The internal anal sphincter is hypoechoic, and then the external anal sphincter has a mixed echogenicity, but is more hyperechoic. So this is just a representation of the mid-anal canal. The hemorrhoidal tissues and subepithelial tissues will look this sort of gray. This black is the hypoechoic internal anal sphincter. And then outside, right here, this is mixed echogenicity. This is the external sphincter. Sometimes you can see a nice bright white line right outside the internal sphincter. That's the longitudinal muscle coalescing. These are representations of the upper anal canal in a woman versus a male. You can see sort of the wider shape of the puborectalis sling here. This is a more narrower pelvis and a more acute U. Mid-anal canal of a female versus a male, just more elliptical in terms of its structure for the male patient. These are some pathology of mid-anal canal. This is a patient that's had a distal, like a patient had a fissure and someone actually did a dilatation. So you can see a fractured internal anal sphincter. It's not continuous. And then what you will see sometimes is that if you're imaging somebody for incontinence and you see a sphincter that looks quite wide and quite hypertrophied like this, you may want to search further to see if they're prolapsing, because this can occur with the trauma of prolapse. In the mid-anal canal, you can try to see and accentuate whether there's a sphincter defect by putting a finger in the vagina of a female patient. So this is the fingertip in the vagina here, and you can actually measure the perineal body measurement. You can measure the size of a sphincter defect. This is an image of the transverse perineal muscles that are coming in that you can actually see in a patient. And then the distal anal canal is where you're distal to the inner sphincteric groove, so you have loss of the internal sphincter and you just have external sphincter muscle. So in terms of looking at fistula's disease, it's not recommended in our practice parameters to do routine imaging. And I would say that I don't routinely image all patients that have anal fistulas. I think, you can obviously see a lot of these patients. You can examine them and tell if they have an intersphincteric fistula. But I do use it fairly liberally because I do think it helps in counseling a patient. I mean, I think you can just take a patient to the OR and do an exam under anesthesia, and then they can come out with a ceton or they can come out with a fistulotomy. But I do think that as a patient, I would like to know what operation I'm going to have and what my recovery is going to look like. And so I do think that the imaging can be quite helpful for counseling a patient. And then I do think that, especially in women who've had vaginal deliveries, it can help to have a baseline understanding of what their sphincter looks like. So this is a patient of mine who had a complex fistula. So we inject hydrogen peroxide into the external opening of the fistula, and the hydrogen peroxide, the bubbles, will show up bright white on an ultrasound. So what you can see on this is that this patient has an internal horseshoe in the intersphincteric groove here on the left side. And then outside the sphincter complex, the patient has a horseshoe as well. And then if you go over here and you're looking in the sagittal view, you can see where this is coming in through. So this is a posterior midline fistula coming through, and you can actually measure how high this is above the intersphincteric groove and how high it is from the anal verge. So it gives you some planning and counseling mechanisms by looking at that. This is another patient of mine who had had a previous vaginal delivery. She had what appeared to probably be a transsphincteric fistula. You can see that on this image over here. You can see right here that this fistula is actually coming in above where either her sphincter closes or she has a full sphincter injury. When you get down to the non-opacified views, the views I did before injecting the peroxide, what you can see is that she actually has an internal sphincter defect. And then you come down a little bit below this, you can see her external sphincter muscle is actually intact. So this is a patient that we put a ceton in, and because she had this internal sphincter defect, she's not a candidate for a lip. So she underwent an endorectal advancement flap a couple weeks ago. So this is an example of rendering and sort of what our 3D views can look like. This is a patient I just saw who has fecal incontinence after having a vaginal delivery. So here you can see me scrolling up from the outside toward the inside. So here I'm getting toward the level of the puborectalis right there. I'm going to scroll back down, and we're not quite seeing those nice two circles that we would like to see. So here, that's where I'm measuring the patient's external sphincter defect. And so this patient actually has a combined internal and external sphincter defect. So I can come in from the side, I can rotate the image. I can measure if the patient did have a little bit of a sphincter anteriorly, like what the length of that is. But really, she has just a tiny bit of scar distally, but doesn't really, there's a big black nothingness in this front area right here. The machine will also take computer averaging and give a rendered image. So this is more of a rendered image, so you can see like the break of the muscle right here, and that here there's nothing, no muscle, no internal sphincter, no external sphincter muscle. So this is a patient that's being considered for sphincteroplasty given her symptoms. So I'd like to move on to anorectal physiology testing, and we will talk a little bit about manometry. We'll very briefly touch on neurophysiology. I think we use that less and less in our practice, although some of the big GI labs will still use that. And then we'll talk a little bit about dynamic imaging. The conditions that we're going to talk about mainly are obstructed defecation and fecal incontinence. And then I use it also for patients who have rectal prolapse and rectocele. So the balloon expulsion test is really just a screening test for patients with obstructed defecation. This can be done in your office if you're referring people on or you suspect that they have obstructed defecation. What you're really doing is you're putting a well-lubricated balloon, having the patient put it in privacy in the bathroom, and then it gets filled typically to 50 cc's. The patient will sit on the toilet, and then the patient tries to expel the balloon. Typically, it's thought that you need to be a normal test or a negative test, that you have to pass the balloon within 60 seconds. So it's a decent screening test for obstructed defecation, but definitely there are patients who do have ODS that can pass the balloon, and there are definitely patients that don't have ODS that can't pass the balloon. So again, its sensitivity and specificity are not the highest, but it's a simple, easy test that can be done in the office. So what we're really here to discuss is anal manometry, and these are the different things that we're looking for. So the resting anal pressure is really a reflection of mainly internal anal sphincter function. So about 30% of the resting pressure can come from the external sphincter, and up to 15% can come from the anal cushions. But typically we think of resting pressure as internal anal sphincter function. On the other hand, squeeze pressure is where it's reflective of the external anal sphincter, that striated muscle that we have voluntary control over. And really what you're looking at is the squeeze increment, which is where you subtract the resting pressure from that. So you want to see how much additional force that you can get from voluntary external anal sphincter contraction and puborectalis function. And then you can look at the duration of the squeeze, because some people can get a high squeeze, but it doesn't last very long and it shows fatigue. You can measure the anal sphincter length by manometry or a high pressure zone. Rectal sensation is one of the important components of manometry. You can look at capacity and compliance. The anal sphincter reflexes, which is the RARE, the rectal anal inhibitory reflex, is a screening test for Hirschsprung's disease. And then in terms of dynamic maneuvers, we don't usually use cough very often, but Valsalva is very important, because what we want to do is we want to see what the sphincter is doing during this Valsalva maneuver to look for obstructed defecation. So there are a lot of different systems you can use, and I wanted to just show you two different examples. So on the left here, this is a 2D disposable probe. So this is what we use in our office. So there's a balloon, there's 4 sensors for 4 quadrants right here, and then you can see these numbers. And so when we do the manometry, it's a stationary pull-through technique, and the technician who does the exam is moving this and getting data at different stations, typically 6 stations. We're measuring usually over 6 centimeters of the anus and the rectum. On these probes right here, these are disposable. They're very easy to set up. They have high reproducibility and can generate fairly accurate data. On the other hand, this is a 3D high definition anal manometry probe. This is what's used in most academic centers. And when these are reusable, they're very expensive. If they break, they're hard to process. They probably are used at lower volumes because of this. And but they generate these quite elaborate pictures, and you'll see some in the upcoming slides. And there's a lot of impressive formatting of the data. And really you can get, there's almost like 256 different data points that are melded into a more continuous computer generated image to look at. So one of the things we mentioned is on the manometry, we want to look at the Valsalva maneuver, and what should happen then is that your external anal sphincter should relax during Valsalva, because that's what's going to let stool out during defecation. So lack of relaxation or the opposite, contraction, that's going to cause obstructed defecation. So contraction is paradoxic contraction, or a lack of relaxation we refer to as non-relaxation. So Satish Rao has described 4 different patterns of dysenergic defecation that can be obtained or measured on anal manometry. So type 1 is where the intrarectal pressure rises, and that's what we want it to do, but the intraanal pressure increases, which is what we don't want it to do. Type 2 is when there's no increase in pressure, it really just stays the same, and there's also an increase in intraanal pressure, 2 things we don't want. Type 3 is when the intrarectal pressure correctly rises, but there's no change in the anal pressure. And type 4 is when there is no increase in rectal pressure, but there's also no change in the anal pressure. Really, there's just no movement whatsoever. So this is an example of a patient that has paradoxic contraction on the right. Here on the left on 3D manometry, there's normal relaxation when the patient's asked to Valsalva. Here you can see the elevation, you can see how the computer formats the image of paradoxic contraction. And this is what the 2D images would look like, where you just see the elevation of the pressures during paradoxic contraction. So the rectoanal inhibitory reflex, I think it's important to understand like what it represents and why we're looking for it. So it's elicited by filling a balloon within the rectum. Typically, it's 30 to 50 cc's of saline that you're putting in the balloon. But you do have to recognize that there are patients, if they have a really chronic obstructed defecation, their rectum is going to be a bit chronically distended. Or if they have really blunted rectal sensation, you might get a false negative or false positive test. So it's important to keep trying to elevate your balloon volume to see if you can get the reflex. So the distension of the rectal wall, what it typically will do is cause first a contraction of the external sphincter muscle. So you'll see a blip increase in pressure, and then a quick relaxation of the internal anal sphincter muscle. So you can see a decrease. So you can also not see a rare in patients who have super, super low resting pressures, because it might be hard to measure that difference. So that's one other thing to be aware of. So the rare reflex is thought to be created to help with the sampling mechanisms of the anus. So what it is that if the rectum gets distended, the sphincter relaxes a little bit just so it can allow the person to note, is this gas? Is this more than gas? So the whole idea of the rare reflex is thought to allow for sampling and discrimination. So here we have, you can't really see the external sphincter uptake on this one, but the balloon's inflated, you get a quick external sphincter muscle contraction, and here you can see the decrease in pressure related to the internal anal sphincter relaxation, and you can see this in the 2D measurements right here. So there are 4 different measurements, or 3 different measurements we do for rectal sensation. You can use the others to measure rectal compliance. And mainly these volumes are looking to see whether the patient feels distension appropriately. Do they get more pain and more discomfort at a lower volume than average? We see that a lot in our fecal incontinence patients. You know, for patients who have very blunted rectal sensation, that it takes a huge volume before they feel it. Those are patients that I'm always a little bit more nervous and more wary about operative intervention of other findings, just because the blunted rectal sensation does seem to be a thing that's a bit more difficult to overcome. Blunted rectal sensation may also be another target for biofeedback therapy. There are some therapists that will do balloon volume sensory training to help treat patients. So another thing that's important to know is that between 2014 and 2017, there was an international group of both gastroenterologists, neurophysiologists, and colorectal surgeons that got together that made a consensus about, you know, how should manometry be performed, how should it be read, and how should it be reported. And really, they were trying to do something that was very similar to the Chicago criteria for esophageal manometry. And so that's what the London protocol is. And so what they do is they state that in reporting the data, really what you're looking at is these 4 categories. You're looking at disorders of the rectoanal inhibitory reflex, the rare. You're looking at disorders of anal tone and contractility, so internal sphincter dysfunction and external sphincter dysfunction, disorders of sensation, and then disorders of coordination, which is really what we're mainly looking at a lot of the time, except for the weakness issues. So major findings include absence of the rare, anal hypotension or hypocontractility, meaning anal internal sphincter dysfunction or hypocontractility of the external sphincter muscle, and then both rectal hyposensitivity and rectal hypersensitivity. Minor findings will be patients that have hypertension, anal hypertension. You'll see these patients that have really tight internal anal sphincters, like patients that have dyssynergic defecation and also who have anal fissures, and then dyssynergy, which we talked about the 4 different types that Satish Rao described. So I do wanted to give you just a little bit of a hint for people who are thinking about doing manometry in their clinic or bringing it to their practice. It's important to know that there are two different codes to bill. We always think of manometry as the 91122 code and measuring the strength, but it's also important that the sensation codes are actually completely different and actually tend to generate more in billing for the procedure. One of the neurophysiology tests that we tend to use still, mainly because it's such a good thing for biofeedback therapy, is surface EMG. What we are trying to do is get a global sense of what the sphincter is doing. You can use an external anal monitor, which is what we use right now. There's also an anal plug, which is often used for biofeedback therapy. And what it does is it just shows a very global sense of what the sphincter complex is doing during the squeeze, rest, and push maneuvers. Again, we like it because it's often what people will use for biofeedback therapy for both fecal incontinence and obstructed defecation. So this is an example of two patients. This yellow is the rest. There's an orange bar, that's the squeeze. The greens are the push. So what we want to see is when the patient squeezes, you want to see a high uptake in activity. When the patient pushes, you want to see it lower than at rest. And so this is normal. Whereas on this patient, it goes up, but maybe not as much as in the squeeze because there's probably some fatigue here. Excuse me. And then when these patients push, there's a high range of activity showing paradoxic contraction right there. Pudendal nerve terminal motor latency, we have gotten away from doing because there's so much variability in the results, and we don't really use this in the past. In the very distant past, there were some centers that felt that if you had bilateral pudendal neuropathy, that you weren't a good candidate for a sphincteroplasty. Other centers didn't believe that data. What you're really doing is you're stimulating the pudendal nerve intrarectally with the fingertip, and then you're measuring the muscular contraction of the external sphincter muscle based at the lower level here. A normal latency was 2.0 plus or minus 0.2 milliseconds. It's really very operator dependent, and again, not super useful. But what it's important to know is that there are labs, GI labs, that are looking at other nerve motor latencies done either from the lumbar or the sacral nerve levels. Similarly, trying to look at nerve conduction, and but there's not really, it doesn't really change what we're doing in terms of therapies as of yet. So dynamic imaging, I wanted to go over this a bit. This is looking for both patients with obstructed defecation, really trying to see, is this a functional problem? Is this an anatomic problem? Is it both? For prolapse, you can identify multi-compartment disease. I think it helps me prevent recurrences by looking at the anatomy of the prolapse. And then I also want to make a recommendation that I do think it can be helpful for imaging our patients with fecal incontinence. What we're looking for is both structural abnormalities, pelvic floor descent, intussusception, prolapse, rectocele, enterocele, as well as the functional abnormalities. So this is a really old study, but I still think it's important that, you know, you can miss a lot on a physical examination. So I do think that imaging can be important to get a whole picture of what's going on in the pelvic floor. We're going to really mainly stick with defecography and dynamic MRI. Pelvic floor ultrasound is pretty interesting and pretty neat, but very technically demanding and not really well reimbursed to my understanding in the United States. And I've dabbled in it a little bit, but I haven't really stuck with it. So we do a lot of cine defecography at our center because it's easy to perform, and it's done in the upright position. And we really feel that having patients pass contrast sitting up is much easier and much more natural, although still bizarre for them, than lying on their side and trying to pass contrast. You can get all the compartments, but you are giving the patients ionizing radiation. You know, you can't beat some of the superior soft tissue images that you see on MR defecography. It really is better at looking at all of the compartments, and there's no radiation. But again, what we struggle with is trying to find a dedicated person to read the images and to really look at what we're looking at. So I wanted to go through a few normal parameters. So what you hear about the anorectal angle, what that really is, it's the line of the posterior border of the rectum to the central axis of the anal canal. So that's this line to this line. This green box is the anorectal junction, which is where the rectum tapers off to the anal canal. And at rest, this is normally 90 degrees. And what it does is it straightens, it becomes more oblique with defecation. That's what it normally does. The other reference you'll hear is the pubococcygeal line. It's between the inferior border of the pubic ramus and the last coccygeal joint. It's really the line that defines prolapse. It's normal for things to move 2 centimeters below that line during defecation. Anything more is considered a prolapse of the organ. So again, during normal defecation, this is the start. With evacuation, you get straightening or more obliqueness of the anorectal angle. The anal canal shortens, the pelvic floor distends, you get good opening of the anus. It's important to know that not everything is pathologic. You'll get these MR defecography reports, and it sounds like there's a million seals that you'll see there. Rectoseals can be really common, and in some studies, up to 93% of women, regardless of parity, will have a rectocele. Intussusception can also be common, up to 20% of patients who are people who are imaged that don't have any symptoms. Evacuation is not always in one fell swoop. It can take on average 2 attempts to evacuate, and it's normal not to evacuate all the contrast. It's thought that most people will evacuate 68 to 82% in normal without symptoms. So these are MRIs looking at paradoxic puborectalis syndrome. At rest, you see the baseline image. When you squeeze, your anorectal angle should be more acute or 90 degrees, so that's correct. And this looks very similar to our first, so this is a component of non-relaxation. This one is even more dramatic. This is at rest, anorectal angle about 90 degrees. With squeeze, it becomes a little bit more acute. With Valsalva, it becomes even more acute. You can see this functional narrowing. And you can see almost like there's this little bit of a rectocele, this outpouching here. You can see how really this puborectalis is driving this pathology by doing the opposite. So the rectocele is an innocent bystander in this situation. So here is a patient who has a rectal intussusception. This is a defecography. So what we can see on this patient with obstructed defecation, the rectum pushes forward. You can see that this anorectal angle is a little bit a component of non-relaxation. This intussusception is probably what I would call a grade 2 or grade 3. And this is probably a patient I would start off with biofeedback therapy first before any operative attempt. And then on the other hand, there's this patient who basically the anus opened up pretty well. You get this widening of the rectovaginal septum. I'm going to play it again so you can see. You get the sense that there's this bowel coming in between the two. And you can really see that the pathology here is what's preventing this contrast from coming out. There's a grade 4 rectal intussusception and a large enterocele that's preventing this patient from getting all the contrast out. So that might be somebody who a ventral rectopexy could be helpful for. So I do want to make an argument about how high-grade intussusception should be thought about in our patients with fecal incontinence. There are some studies that suggest that patients that have high-grade rectal intussusception and fecal incontinence, some of them will present with only FI, some of them will have only obstructed defecation, but really a lot of patients with high-grade intussusception will have a mixture of fecal incontinence and obstructed defecation. So in your fecal incontinence patients, it's really important to tease out the obstructed defecation symptoms as well. And the mechanism of fecal incontinence in these patients is thought to be related to the intussusception based on the fact that we know that with deeper intussusceptions, so intraanal intussusceptions, you get weakness of this internal sphincter from this dipping down and stretching this out. So maybe not as much in the grade 1s or 2s prolapses that are intrarectal, but if you get a grade 3, which is the upper anal canal, or a grade 4, which is halfway into the anal canal or lower, you can see that there's damage that can be created there by that internal prolapse. It's also thought, we talked about the rare and how, inflation of the rectum leads to relaxation of the internal anal sphincter muscle. And so the question is does this intussusception cause that rare reflex and cause anal hypotonia that causes incontinence? And then the more easier one to understand, and what I think we see the most, is that, often patients will have incomplete evacuation, obstructed defecation symptoms, and then they walk around and then they leak out little pellets. And it's because they can't empty related to this. And they have anal hypotonia related to this that causes their fecal incontinence. So on this, here's another patient who had fecal incontinence. She also had some obstructed defecation symptoms. So she's here getting her internal prolapse right here. And then what this will often look like on the manometry is that they'll have these very short sphincter lengths. So we only see a high pressure zone of 40 in the distal 1 centimeter, but then they'll have preserved squeeze increments. So their external sphincter muscle is good, but they have weaker internal anal sphincter muscles. When I see manometry that looks like that, I'm expecting to possibly see something on the defecography. All right. So this paper came from the Oxford Clinic in 2015. And this was looking at the success of SNS in patients who had high-grade internal rectal prolapse, so intraanal prolapse, versus patients who did not. And you can see that when they did the test phase, that there was more success in the non-HERP patients, but there was a fairly good success initially in that short time frame where they were testing the patients. But when you looked after the patients were implanted, and if you had a fairly high criteria of decreasing the PHYSI, which is a continence score, by greater than 50%, it was much better in patients who did not have HERP, and it was very low in patients who have high-grade intussusception. Interestingly, they found that the GI quality of life only improved in the patients that didn't have HERP. And this is probably because these patients that do have HERP probably also have obstructed defecation, which would affect their GI quality of life score. And so the conclusion is that a high-grade intussusception that can have a detrimental effect on the success of neuromodulation treatment for FI. So we looked at our patients similarly with this. And I have to say that I've sort of drank the Kool-Aid from the Oxford group, and I feel like I saw this. We had a smaller percentage of our patients that had rectal anal intussusception, and we actually found that our patients that had an intussusception versus not were pretty similar with their results of neuromodulation therapy. So we could not prove the Oxford Clinic's point on this, but I do think that there's something there. I do think that in our paper, we probably had less patients that had the grade 4 rectal intussusceptions. So I think it's just something to be aware of, that if your patient has obstructed defecation, in addition to their fecal incontinence, you may want to consider dynamic imaging. If you have a patient that didn't improve after neuromodulation therapy for fecal incontinence, maybe you should get dynamic imaging. It's just one of those things to think about, whether that's contributing to their symptoms. So this is how we developed our accidental bowel leakage protocol. Patients who have rare symptoms or are not surgical candidates will go into the biofeedback arm. We don't do a lot of injectables anymore, but those would be patients that we would consider. Patients that are candidates for sphincter repairs are patients, to me, that develop symptoms of fecal incontinence right after the trauma of the delivery. So those are the patients that I'll do the ultrasound on, and usually also some anorectal physiology to see, does the muscle contract as well as having a defect? And those are patients that I look at for overlapping sphincteroplasty. For patients who had their symptoms much later in life of incontinence after traumatic delivery, or have no relationship to the delivery, those are if they're in good condition, those patients who I will do a defecography as part of my whole testing and consider for ventral rectopexy. For patients who have mainly urge incontinence, Or if a patient's had like previous radiation and there's no way I'm ever going to go into their abdomen to do or put mesh in their abdomen, those are patients that, if they have significant enough incontinence, maybe they can go right to the peripheral nerve evaluation. Maybe they don't benefit as much for anorectal physiology testing. Those are patients on the SNS pathway in my eyes. On the other hand, how to put this together for your constipation patients. So this algorithm is really for patients who have failed over-the-counter medications for constipation. So the next step, based on most of the GI societies, is then to do anorectal physiology testing. And the reason behind that is because prescription constipation medications are quite expensive. They don't work as well for patients who have obstructive defecation. So you want to weed those patients out before putting them on the Linzess and Amitiza and all of that. So patients who have normal manometry and balloon expulsion tests, they go on to do the transit study and they get all the medications. The patients who have abnormal tests based on the GI algorithms, those are going on to the defecation disorder pathway. If there's anything inconclusive, those are the people who they recommend imaging. So in that same AGA pathway, a lot of those patients who are decided to have a defecation disorder, they go through biofeedback therapy, they see a dietitian, you can repeat the balloon expulsion. And if it's normal, then they move on to the transit pathway. But then if it's abnormal, you go on to your dynamic imaging. So on the other hand, a colorectal practice, this is really how we do it. We do the manometry, EMG, and dynamic imaging, and then we really figure out what's going on all at once. So if they have pure anismus, they go into the biofeedback pathway. Patients who fail this may go on to Botox injection later on. If they have anismus but have a full thickness rectal prolapse, we'll fix the rectal prolapse first, but sign them up for the biofeedback therapy after. It's really hard to do biofeedback therapy when you have a full thickness rectal prolapse, so I really don't make my patients do that. If you have anismus, but have but then you have like a non-full thickness rectal prolapse, you go to the biofeedback therapy first. And you can make it to the surgical correction arm if you pass your biofeedback therapy, or if you're counseled extensively, and this is the only thing we can think of to make you better. And then if you have normal relaxation, so your coordination is good, but you have rectocele, rectal intussusception, rectal prolapse, those are the people we'll take on to surgical repair without doing biofeedback therapy or anything else first. So that's my quick and dirty algorithm for anorectal physiology testing. That's some hints on ultrasounds. I hope this is helpful for when you guys are taking your boards, and I'm happy to answer any questions.
Awesome. Thank you, Dr. Thorsen, for that crash course in endorectal ultrasound and physiology testing. That was very informative for myself, and I'm sure for lots of the other fellows out there. One question that we had was for boards exam purposes in particular. When would you, you cited the example of patient with clips in place that need to fall out before an MRI can safely be performed. When would you recommend or cite an endorectal ultrasound as your first line versus MRI for rectal cancer staging in a board setting?
Yeah, so I think there's not really, I think the biggest issue for the actual staging in these post-polypectomy patients is, how long do you have inflammation related to the polypectomy before you do that? And I don't think there's any data out there. So what I would say in the board setting would be is that you would consider doing the ultrasound 1 to 2 weeks after, or your staging MRI if you're going to do that instead. And you just justify that saying you just don't want any peri-procedural inflammation to show a false positive on your staging.
Awesome. Thank you very much, Dr. Thorsen. We really appreciate you taking the time to talk with us tonight. And thanks to all the viewers out there for tuning in. If you missed part of the lecture or want to recap it, it'll be posted on our YouTube channel in the next couple of days. So thanks, everybody.